Hey guys, I was so excited to see that you enjoyed the first video interview with Dr. Dave Stukias, the world-renowned pediatric allergist and immunologist. Well, here's part 2, where we answer some of the most common questions people have about allergies. Boosting your immune system through supplements, hypoallergenic pets, growing out of allergies. There's so many great tidbits that are going to be answered in this video. I hope you enjoy. If you have any residual comments, always feel free to leave them down below. And are you ready? Something common I have, a patient comes in and says, I have dog allergies, but I'm about to get my first pet, and it's going to be one that I've researched and it's a hypoallergenic pet. What say you?
I say that there is no such thing as a hypoallergenic cat or dog.
There is no such thing as a hypoallergenic cat or dog. Sorry, Bear.
All dogs and cats release dander, and the dander comes from saliva, their skin cells, and their urine. They all produce dander, and for the person who has allergies, if you're exposed to that dander, you can have symptoms. Now, when it comes to, say, dog allergy, absolutely, there are a lot of people out there that are allergic to some breeds but not others. We just can't figure that out unless you're actually exposed to it. My advice for families when somebody has a dog allergy, I say, and they want to bring a dog into the home, go find the breed you want, spend time with it, rub your face on it. If nothing happens, you're probably going to be okay. Even if symptoms occur, we have some avoidance measures that we can do once the pet's inside the home. But if you do that and you're a mess because your eyes are swollen shut and you're coughing and wheezing, maybe, let's find a different type of pet.
Yeah. There is something you can do if you are allergic to dogs and you'd like not to be, and that sort of brings us into our next point, which is what treatments are available for those who do have allergies and want to get rid of them?
Yeah, so if we talk about, environmental allergies, things that would cause itchy, watery eyes, sneezing, runny nose, it's important first and foremost to know, are you truly allergic? I'm not one for over-testing, but when it comes to allergy testing, it's really helpful to establish the right diagnosis, because we want to talk about avoidance measures as well. And there's a lot of symptoms, a lot of causes that kind of mimic allergies. So you can have just recurrent viral infections, weather-related issues that cause rhinitis, things like that. So if there's any question about it, if you're trying some treatment options, it's not working, then that's the way to go. But we have great treatment options, so antihistamines are the old standby. Now, we used to use things like diphenhydramine, which is the trade name Benadryl, and these first-generation antihistamines for decades, because that's all we had. We don't have to use those anymore. We have very well-established, long-lasting, non-sedating, second-generation antihistamines that will treat itching, sneezing, runny nose, but they don't work very well for treating nasal congestion. By far, the #1 treatment for all symptoms affecting the nose would be a daily nasal steroid spray. So you use it every day. Over time, it helps decrease the inflammation, the swelling, and your symptoms improve. So those are the mainstays. Of course, we have immunotherapy or allergy shots, which have been around for over 100 years. So when you're doing all the right things and trying to avoid what you're allergic to, taking medications, you've gone up the treatment ladder, and you're still suffering and miserable, we can help you. And we can actually take what you're allergic to and dilute it down and inject it back into the body through shots, build it up over time till we reach a maintenance dose, keep you on that for several years, and desensitize you to your allergies. Some people are even cured. And there are some people that use sublingual drops. You put them on the tongue, which works sort of the same way.
All these options are really interesting. You talk about the sedating properties of Benadryl, right? And actually, people use Benadryl for its sedating properties. Like you have the Z-Quil or Z-Quil. I don't even know the proper term for that. You also have it in like Advil PMs and all those. They basically have a form of Benadryl in them to help you get sleepy. But now, if you don't have to use Benadryl, you really shouldn't, because of a very specific study you talked about on Twitter, which I love this study. The study actually talks about the level of impairment you experience with Benadryl versus things like alcohol while driving. Talk to me about that.
Oh, my favorite study as well. So there's the Iowa driving simulator. So they took research subjects and they put them in 4 different groups. They got baseline measurements to see how they're driving. Are you hitting the cones? Are you impaired? Things like that. And then one group took 50 milligrams of diphenhydramine or Benadryl. Another group drank alcohol till they were legally drunk.
Sounds like a good study.
Yeah. Another group took a non-sedating antihistamine, fexofenadine, trade name Allegra, and then we had the placebo group. And then they took all the baseline measurements, and then after they were exposed to these different types of interventions, they had them drive again. They found that the group that took Benadryl were more impaired than those who were legally drunk, but they weren't sleepy. So that you can't use sedation to know if you're impaired. And that's a really important concept. There's a reason why pilots are not allowed to take Benadryl for 30 hours before they get in a cockpit, because it can cause impairment. If you are taking these old first-generation antihistamines, you should not be driving cars.
Or operating heavy machinery,
No.
or working maybe even as a doctor in some cases, right? You
Right.
can make some bad decisions as a surgeon in an operating room.
Absolutely.
These are all things that we need to consider. So it's really a great piece of advice that if you can go for a second generation antihistamine, the Allegras, the Zyrtecs, the Claritins of the world, those are all options for you.
And they're all over the counter.
The thing that I notice when I recommend this to a patient, they'll say it's over the counter, great, I'll use it. They expect results from day 1 or 2 because they're used to using things like Afrin, which is a nasoconstricting spray, which is not great long term because it causes rebound congestion and all those other problems. Like you use it, you feel great, 3 days later you stop and all of a sudden it comes back even worse. So now they're used to this instant relief from one of these nasal sprays. They use Flonase, they don't see it, they think it failed. But in reality, what's happening?
Yeah, so it just takes time. So when we talk about using steroids of any type, they're not immediate, fast acting. So for a nasal steroid spray, you really have to do it every day consistently. And then most people start to feel some benefit within a week or two, and then we want them to keep using it because that's the way they're designed to be used.
Let's talk about something I hear quite often in my practice is that milk causes, or the consumption of milk causes increase in mucus production. What say you?
It's a myth.
Okay.
Yeah, so there's actually a great review article in the British Medical Journal that really goes through, the lack of evidence to support that. We hear it all the time, right?
Sure, yeah.
People are told, professional singers are told to never eat dairy or things like that.
Yeah.
People with asthma are told to go dairy-free. So milk does not increase mucus production. There's a lot of people that already naturally produce a lot of mucus and you get the phlegm and the postnasal drip. If you're drinking a lot of milk, it can maybe make that a little thicker, the sensation a little thicker.
Sure.
But more often than not, it's just a placebo or a nocebo of, it's just something that you're doing and you're already sick in the first place. But there's really no evidence to support it.
Yeah. If you want to get rid of the mucus, some nasal saline, staying well hydrated, because when you're dehydrated, everything kind of clamps up in there, makes it difficult to breathe. But milk, not the culprit here.
Yeah, like pancake syrup, a lot thicker than milk. Nobody's out there saying don't eat pancake syrup, you have a cold.
It's a good time to bring up food journals. I like, or symptom journals with my patients when we're unsure if something is causing an allergy or they're unsure about their symptoms. Because to be fair, like I don't remember what I ate, last week. It's hard, but when you actually put it down on paper, that becomes an objective measurement and takes away the subjectivity of it somewhat.
No, I agree. I think journals are great because, like you said, we're all fallible and we forget things. Yeah. We know this from studies looking at juries and testimony and crazy stuff like that. Our minds are very interesting places. But a journal is nice for a couple of reasons. One is it more accurately you can record things and share it with your personal doctor and go over things. But it also puts the timing in perspective. Because we know just by certain mechanisms, like with a food allergy, it's going to happen pretty fast after eating a snack or a meal. Yeah. So if your symptoms occur 3 days later, we don't even need to worry about what you ate. In that period of time.
Very well said. Let's talk about a condition that I run into fairly often in my practice, at least fairly often in an undiagnosed fashion, that they don't even know that they had an allergy. The typical history is a patient comes in and says, look, I don't have any allergies. Occasionally I get a stuffy nose or a runny nose during the springtime. But then when I eat specific fruits, some vegetables, I get an itchy mouth. Talk to me about what could be going on there.
Yeah, oral allergy syndrome. I guarantee somebody out there watching this has oral allergy syndrome. All right, so you're not losing your minds. This is a real thing. Yeah. This goes to the similarity in proteins. If somebody has outdoor pollen allergies, things like trees in the springtime, grasses, weeds in the summer, ragweed in the fall, fruits and vegetables often contain similar looking proteins to the pollen that causes your itchy, watery eyes, sneezing, runny nose. Most of the time, these proteins are on the skin or on the outside part, and you can very easily sort of degrade them, break them down, and get rid of them. Part of the reason that you only have symptoms in your mouth, which we'll talk about in a second, is because our saliva actually helps break them down. So oral allergy syndrome can occur when people have outdoor pollen allergies and you eat a fruit or vegetable, typically when it's fresh, that is similar to the pollen that you're allergic to, causes itching, tingling inside your mouth and throat. Very rarely, it can progress to a more severe allergic reaction, but most of the time, it's just discomfort inside the mouth. Now, the cool thing about oral allergy syndrome is oftentimes you can still eat the same fruit or vegetable if you cook it, if you peel it, if you can it, or if you prepare it in some way. And the classic example is I'm allergic to tree pollen in the spring. If I eat a fresh apple, my mouth goes crazy, but I can eat apple pie all day and I'm fine.
For those patients, do you just give them the guidance of changing the preparation of their food, or do you put them on a medication? Do you have them have an EpiPen? Or what's your strategy for that?
Yeah, we also want to be real careful, make sure we're not missing a true food allergy, which can progress obviously. But oftentimes it's just education. They can work around it. Sometimes it's seasonal, and they're fine with apples in the wintertime, but then they have issues in the spring when their allergies are already kind of flared. standard. Sometimes an antihistamine can help prevent some of those symptoms. And then some patients who actually end up getting immunotherapy or allergy shots, all those symptoms go away as their allergies get treated.
Being a pediatric allergist, you not only deal with the patient, you deal with the patient's family, parents, guardians. That's got to be a challenge, especially with all this anxiety.
It is, but I love it.
Okay.
Because you're right. I have to try to figure out, can this child, if they're young, they can't verbalize, and they're not, what's actually going on with them. So what's the real likely diagnosis, perceived diagnosis from parents? And then I have to, help educate the caregivers. You're the ones who have to go home and live with this every single day. I see you in the office a few times a year, 20, 30 minutes at a time, but how can I give you the skills and the empowerment to go home and live with this and navigate the world where you don't have to watch your child sleep every second of every night, worried that they're gonna, something bad's gonna happen. It's a fun part of the job. I continue to try different approaches to it. The whole social media online world has really given me a lot of great insight into the fears and concerns, and I address that with families now. And I talk to them about these anxieties, and oftentimes they'll tell me I'm the first physician or medical professional that's really openly asked them about it, and then they open up. And you can just see the weight go off their shoulders, so it's great.
For sure. Do you ever guide them to resources online that may be something that you've published? Do patients appreciate that?
Yeah, absolutely. So I acknowledge it. I say, listen, I know you're going to go online to look for medical information. I do it as well. It's the world we live in right now. Be very careful, because there's a lot of misinformation out there. Here are some vetted resources pertaining to your condition. And lastly, I tell every single family, if you come across something that raises concerns, write it down and call me. I'll talk to you about it. I'd rather talk to you for 10 minutes than have you lose sleep for a week thinking that something is a real risk when it's not.
That's awesome. I see a lot of newborns in my practice, or at least infants. Very often, I get presented with patients coming in and saying, oh, my child has X milk allergy, cow's milk, goat's milk, there's all sorts of things being presented to me. Do you order allergy testing on all these patients, especially with them being so young? What's the normal route that you like to take with those patients?
Yeah, so that's a great example of the important distinction between a true allergy, and even if it is an allergy, what type of allergy. So the allergy tests that we do only evaluate for this IgE, immediate allergy response. If an infant or child is experiencing rapid onset hives or swelling or wheezing or vomiting after eating dairy products, and it happens every time, that raises suspicion for the IgE allergy.
Which is the true allergy.
The immediate hypersensitivity. They can have a delayed allergy, so in infants, young infants, it's, they present with, they're on a milk-based formula, or sometimes mothers are ingesting cow's milk and they're breastfeeding, and they get the painless, bright red blood in their diapers.
Yeah.
So that is also considered an allergy, but not immediate onset IgE. We can't test for it. It's a clinical diagnosis, as you know, and you take milk out of the diet, and that magically resolves as the gut heals, and then you can just introduce it again when they're older and more mature. So that's a different example. We don't need to do IgE tests for those babies. So it really gets down to, what's actually the likely diagnosis by the history, but it also points to infants will have symptoms. So reflux is not a medical condition.
Yes.
It's a condition
That's
of being a baby, right?
Yes.
Yeah.
Because that's the number one question.
Absolutely. So babies spit up, and we get caught in this formula roulette. Like, we started on this formula, they were spitting up, so we switched to this formula, and then and you're on these expensive, disgusting, hypoallergenic formulas, which may not be necessary in the first place. So it's getting comfortable as the physician, seeing enough babies and say, okay, I think that this is likely just a normal part of the spectrum. They'll grow out of it as they get older. Let's not make any drastic changes, but also, providing that reassurance to parents, of course, but also being able to recognize, okay, I think this is crossing over into a different realm here.
Sure. I like to use the growth chart as the biggest reassurance for patients, because you have to explain to parents, your child will not grow if there's something wrong. If they're constantly being sick, or if they're truly having some sort of immune deficiency, they can't grow. And if you see a child is gaining weight well, is thriving, is playing, the fact that they have reflux every now and then is not a dangerous condition for your child. Yeah. So that's like a line of reassurance I really like to take with parents.
I agree. Reflux is a laundry problem, not a medical problem.
That's well said. A big topic in the media right now surrounds food allergies, peanut allergies. We see the rates going up. We actually had a scare in the 90s that we told parents to stay away from allergy possible foods. And that's actually fueled a bigger problem for us. Where now we've sort of seen the research point in the other direction that we should be doing single food introduction when we do solid foods at 4 to 6 months and do peanuts. And the great study that came out, I believe it was with peanut paste or some kind of peanut snack in Israel.
Bamba.
Bamba,
Yep.
yeah, that's a delicious snack right there. Right. And we've seen that early introduction of these foods actually decreases incidence of allergies. Can you speak on that?
Yeah, absolutely. You're right. We used to think avoidance would prevent allergy from developing, and it turns out that that's not the right way to go. You do the best you can with the information available at the time, and we didn't have great studies that said what happens if we avoid versus introduce. Well, now we do. So the Bamba, where infants in Israel had much lower rates of peanut allergy compared to infants in the United Kingdom who weren't exposed to peanut until after a year of life, really leapfrogged into new intervention studies. The big LEAP trial, this was like a rock star moment when this was published in the New England Journal of Medicine in 2015, changed everything because they took two groups. Infants where they said, let's avoid peanut. Infants there they said, let's keep peanut in your diet from an early age, before 12 months of age, at least 3 times a week until you're 5 years old. And then they challenged all of them to see which ones actually had peanut allergy. Well, those infants that kept it in their diet on a consistent basis had a dramatic reduction in peanut allergy at 5 years of age compared to those that avoided it. So that's led to new guidelines in the United States and Europe and Australia, where we now actively recommend let's introduce peanut and other allergenic foods into the infant's diet around 4 to 6 months of age, once they've already demonstrated the interest and ability to tolerate solid foods. So start with the rice cereals and the purees and things like that. We never want to use whole or partial peanuts, so there's age-appropriate forms such as thinned peanut butter or these Bamba snacks or peanut flour. But now we want babies to eat and keep it in the diet. So it's not one little introduction and then have a nice life. Yeah. It's keep it in the diet, make it a part of the diet. And we're hopeful that by introducing this on a population level, allergenic foods, diverse diets early in life, that we can actually see a shift in the rates of peanut allergy and other food allergies over time. But that's only part of the puzzle. So we don't fully understand why kids develop food allergy in the first place or what's led to the rise in food allergies. It's likely that the way we introduce allergenic foods is part of it. There's something called the hygiene hypothesis that shows it's been documented throughout the world as societies have moved from farming environments where babies are exposed to farm animals and more specifically the poop from farm animals early in life to more clean environments in urban settings, that there's a shift in the immune response. There's a misconception that babies have delicate immune systems. They don't. Their immune systems are robust and they want to go to the gym and practice. And what happens when you don't expose them to germs and bacteria that they can fight off? Their immune systems get bored and they start reacting to things like peanut. Yeah. Peanut is a harmless protein, but that's part of the reason why we're seeing more of these allergies. So it's a complicated issue that we don't have complete answers to.
Of course. Yeah. My mind goes back to that challenge aspect, that the same way we don't challenge our mental state, that if we don't put challenges for ourselves, it gets really boring at times. And what happens? You start building up anxiety. Right now, I think one of the big problems we have in our society, I like to call it, or I'm pretty sure I've read this somewhere, problems of progress. We've become so safe in our mental space, in the fact that no one's physically attacking us, there's no lions, crime has gone down, that now anxiety is prevailing and is becoming a bigger problem. Much how we've become so safe with antibiotics, proper hygiene, boiling our water for our kids, which is crazy. But because of that, we are actually creating a world that's too clean and therefore not challenging us enough, and it's creating new problems like allergies.
Oh yeah, I think that's part of the puzzle, absolutely. And it's kind of interesting, the IgE allergy antibody, initially our bodies developed this to fight off parasites.
Yeah.
Yeah, we don't have to worry about that a whole lot anymore.
Which is a test we do, that if we're considering parasites.
Yep, absolutely. So now that that's gone away, this IgE was kind of saying, hey, I wonder what's going to happen here if somebody eats this food or whatever. So it's a fascinating.
Yeah, it's crazy how the body adapts in positive ways, but also in ways that can actually be harmful to us. For those who had childhood asthma, they're 30 years old, they don't have asthma anymore. What changed?
Oh, that's another great question. So asthma is a chronic condition that affects the lower airways, as you know. It's hallmarked by two things. Inflammation. For some people, that inflammation is a really big part of their asthma. For others, it's not too much inflammation, but everybody has some form of it. And then the second part is recurrent and reversible episodes of bronchospasm. So the muscles around the airways will squeeze and tighten. Asthma can be very severe and can cause life-threatening and fatal exacerbations. Unfortunately, it's 2020 and we have 5 people dying from asthma exacerbations every day in the United States.
Crazy.
It's tragic and it's preventable. Or it can be more subtle and you only have symptoms every once in a while. So part of it goes by what's your history of asthma, and then asthma can change over time, like a lot of chronic conditions, including allergies and things like that. So there's a lot of people out there that had asthma symptoms when they were a child or teenager, and as they become an adult, their symptoms just improve over time. It can also happen the other way as well. So a lot of adults can develop asthma or have worsening symptoms even though they had mild symptoms as a child.
So this is the perfect time to jump in and say, this is a question we don't yet have an answer to. What's going to happen in this scenario? You're going to have, undoubtedly, some expert come in, I like to call them IKA experts, I know all experts, and say, yes, the medical community doesn't have the answer, but I have the supplement that will fix that problem for you. Have you seen that? What's your experience with that?
Yeah, I've come across that every once in a while. Right, so, there's a great quote along the lines of extraordinary claims require extraordinary evidence. So what's the evidence? There's a lot of frustration from people with chronic conditions where we don't have cures. Sometimes we don't even have a great way to diagnose certain conditions or treat them necessarily, and they really suffer. And that leads to, well, what if? What if I choose this alternative therapy or this supplement and you get caught in this dangerous web of pseudoscientific claims and these buzzwords? And then a lot of it has to do with marketing. So a couple of rules of thumb. One, if the person that's giving you the medical information is also selling you a product or a service, that's a red flag. That's a conflict of interest.
Yeah.
So check up with it. Talk to your doctor. Always go back to your personal doctor. I read this online. What are your thoughts on this? Is there any evidence or research to back it up? And then the second thing is really, what's the evidence? Anecdotal experiences are really powerful. There's a lot of people using social media who live with chronic conditions. They tell the world about this is what it's like for me to live with this, and here are some things I found to be helpful, not helpful, things like that. I think that's amazing because the support systems are lacking, and it's really important for people to have somewhere to go to find the support. But your experience does not make you an expert on the disease. It makes you an expert on what it's like for you to live with that experience. There are too many individual nuances that affect our health that make your experience almost impossible to translate to mine. There may be some overlap, but it's really hard to tease that out.
I think a statement I made in one of my past videos was that I do believe patients are experts in their own disease, but they're not experts in the disease. When we see, let's say, heart attacks, now a patient can be an expert exactly what they're feeling, what happened, what medicine works for them, what treatments didn't work for them. But now, seeing that on a population level as a physician is really valuable because now I know, well, if a patient's taking this medication, I know that just because it worked for person A might not work for person B. And I think that's really important for patients to consider that there's a reason why we're doing a lot of these things. Please ask your doctor what that reason is, but don't automatically assume that they're just guessing or that they don't know. Because there's a lot of times we're making decisions where there's a really good reason as to why. What's the biggest mistake you've seen family medicine doctors or general practitioners make when referring to you patients, meaning that maybe they've done some testing or haven't done some testing in the first place? What are your thoughts?
Yeah, number one across the board, and it's not just family medicine doctors, it's primary care physicians and medical professionals, it's the overuse of food allergy IgE tests. Okay. There are these panels that are commercially available, they're heavily marketed. Wouldn't it be convenient to do a simple blood test on your patient and find everything they're allergic to? The tests don't work that way. We can only interpret the test results in the context of a detailed clinical history. So they're not screening tests, they're not pregnancy tests, it's not positive or negative. Yeah. It only helps indicate the likelihood that an allergy may be present. So when we see patients that have already had all these tests done and foods that they're eating on a regular basis and you shouldn't even be testing for, it can be really confusing and hard to sort out. So
that's such an important point. So if you're eating tomatoes and you get one of these IgE blood tests, which is the allergy test we're discussing here, and it comes up positive for tomatoes, that does not mean on its own that you have a tomato allergy. Right. Because if you're eating the tomatoes, we know from the history that you're not having an allergic reaction, so this test is giving us a false positive, which happens, what's the percentage of false positives in these tests?
Some would say up to 50%. Yeah, and you get a range, and you if you have environmental allergies, there's cross-reactivities. So if you have a dust mite allergy, which causes chronic nasal symptoms from your exposure inside the home, you can have a falsely elevated shellfish on testing.
Yeah.
You're not allergic to shellfish necessarily, but it just shows up on the test.
So what do you do in that scenario if, let's say, that cross-reactivity exists, or you suspect that it's a cross-reactivity, and the patient hasn't had shellfish in ages? Yeah. Do you do a challenge, or?
Yeah, if it's been a while since they've had it, or it depends on the level too. A lot of them are real low-level, wishy-washy. So on a scale of 0 to 100, if it's barely detectable, we often will just say, let's go ahead and eat it if they're comfortable with that. Sure. But it's always, you're welcome to come to my office and hang out and eat food.
Yeah, exactly.
It's fun. It's a great part of the job.
As an allergist, you study the immune system, right? An allergy, as we said earlier, is an overreaction of the immune system. What do you say to patients who say that they want to take or are actively taking supplements that are immune boosting?
Yeah, the older immune boosters. When you boost the immune system, bad things can happen, and that's autoimmune conditions, right?
Yes.
So when you have lupus, your immune system is overactive against your own body tissues.
We should rename autoimmune disorders immune boosting.
Yeah. So this goes back to these false claims.
Yeah.
There's supplements. There's specific foods that you say if you eat blueberries, it'll boost your immune system. There's rarely any evidence at all to support that. If there is evidence, it's cherry-picked data from a mouse in a lab where they look at one measure of their blood. But how does that translate to an actual human being, and how much you need to eat or take or things like that? So if you want to boost your immune system, vaccines. That's what they do. Yeah. It's fantastic. Yeah. So a lot of people have concerns about vaccines, sometimes because they don't understand how they work. Vaccines are a way to take a small piece of a bacteria or virus, most often not a live virus that can cause infection, and you introduce it to the immune system, typically through a shot. And then your immune system says, aha, you're a foreign protein, and that you build an antibody response. The first antibody is called IgM, immunoglobulin M. IgM is the abbreviation. IgM then says, hey, guess what? IgG is the protective antibody. That's the soldier coming to the fight. Guess what? We have a new foreign invader here. I want you to remember this guy. If you ever see him in real life, you can mount a fast response and fight it off. So you give a small piece of the protein, your body takes it up without getting sick, you remember it, and then if you encounter it later in life, your body can mount a very effective boosted immune response against that pathogen.
Would you say, the way you said it was awesome, making it very realistic and understandable. Would you say getting a vaccine is almost like practicing for a competition?
Yes.
So the illness is the competition. Do you say, why practice when you can just get more experience through competition? Well, yeah, you can get measles and get immune protection that way, but then you're getting all sorts of risks that way because measles has complication rates, pneumonia, encephalopathy. So why do that when you could practice by getting the vaccine, which doesn't come with all the risks that come with the true illness, and make yourself prepared if measles does come around? That's exactly right.
And the booster vaccines, a lot of people have concern, why so many vaccines? Well, the reason is because just like going to the gym, if you go to the gym and get all buff, like Dr. Mike here, but then you don't go to the gym for a couple of years, those muscles will kind of go away and you forget how to fight it off. So you give the booster so that you get more long-lasting memory.
Perfect. I have patients that come in, they say, I have an egg allergy, so I can't get the flu shot. And they're trying to skirt the flu shot by doing that. I very kindly inform them that that's not a thing. We can actually give the flu shot with the egg allergy. I say that we will have you stay maybe for a longer period of time. We'll watch you in the office. And now something has come out where they specifically make sure that there is no egg component in certain flu shots. So I believe it's called Flu Block. And it's given some reassurance to patients. But in reality, you can get any flu shot. Is that correct?
Yes. So we used to recommend avoiding because when you make the influenza vaccine, oftentimes it's using hen's chick embryos. So the theory was that you could introduce small amounts of egg protein in the vaccine. And we used to avoid it. We would do these torturous desensitizations to kids, 5 steps, things like that. And then in 2009, the H1N1 influenza pandemic hit. And we said people were very sick. We need to find a way to vaccinate people with egg allergy. And since then, there's been over 45 clinical trials that have all shown the exact same thing. People with egg allergy, even if they have a history of severe anaphylaxis, can safely receive the influenza vaccine. It turns out there's either not egg in it or not enough egg to cause a reaction.
And we do this, and I'm sure you've given flu shots in your office with this. I've given it in my office. No one's, I even watched them for a period of time, and no one's ever had a reaction. Like it was something that was more theoretical, and then in practice, it didn't turn out to be that way, which happens in medicine. That's why we look for good quality evidence. There's a lot of times there's expert opinions out there without randomized controlled studies. turns out to be false. That's why we use expert opinion, solely expert opinion, as the lowest form of evidence, and the randomized controlled studies as the ones that are gold standard.
Yeah, and actually you bring up a good point. This is something I've adopted recently with patients in the office, is I'll admit, and I'll say, listen, this is the way we used to do things. The evidence has evolved. This is what the evidence now shows. We didn't have evidence before, now we do, or the evidence has changed our mind on things. And this is where people get frustrated, as you know.
Sure.
Oh, well, we used to say this thing, and now you're saying this thing, and how are we supposed to believe any of it? Maybe I'll just ignore it all. Well, that's what science does, it's progress.
Yeah. There's actually a great book on the subject called The Half-Life of Facts. And it really shows that we need to have a level of humility in science, because we'll say, oh, this species is extinct, and then we'll go to another depth of the ocean, and we're like, oh, wait, no, it's actually not extinct. And
when I was a kid, Pluto was a planet.
yeah, that's true. To me, it still is, because I feel like that's my level of solar system education. But apparently it's just, what, a rock, a moon, an asteroid?
I honestly have no idea right at this point.
I'm sure you guys know. Let us know in the comments. Educate us on the solar system. One of the most common allergies my patients tell me about, especially because I'm a family practice doctor, I see patients with bacterial infections, is penicillin, which basically means that they're allergic to both penicillin and amoxicillin, the entire class. New research has come out to show that the majority, the huge majority, aren't actually penicillin allergic. Tell us about that.
My favorite statistic in all of medicine.
Okay.
10% of the general population reports having a penicillin allergy.
Okay, so 1 out of 10 people will say they're allergic.
But more than 90% of those same people are not actually allergic.
That's a huge percentage.
Yeah, and it's a big problem because it stays with you your whole life.
Now, from my understanding of that research is they had an allergy or allergic reaction when they were children, or perhaps had some sort of reaction that may not have been a true allergy, and then they carry that on into adulthood, whereas if you look at over the age of 10, that a lot of these self-resolve or actually were not allergies to begin with.
Yeah, so the majority weren't a real allergy. So a lot of people have side effects from antibiotics. So delayed rashes are very common, especially in kids. You can have, stomach issues, diarrhea, cramping, and oftentimes it gets labeled as allergy, where it wasn't. It was just a side effect or some weird symptom that occurred while you're sick. Even for those who have a true allergy to penicillin, if you're not exposed to it, that often goes away. And 10 years is kind of the magic. So if you're a kid, even if it was a legitimate penicillin allergy, but now you're an adult, it's probably gone.
Yeah.
And we have very easy tests. We have either skin prick testing we can do in the office, which is very reliable and easy to do. We have challenges. So we now know that, with children especially, delayed onset rash, several days after starting amoxicillin augmentin and things like that, no other, scary symptoms to worry about. Hang out in the office, we give you 2 doses. We give you a 10% of the typical dose, wait 20 minutes or so, make sure nothing bad happens. Then we give you the rest of the dose, have you hang out for an hour, and that at least rules out the possibility of an immediate anaphylactic reaction. And the studies show that 95 to 96% of those kids with that story delayed onset rash, they get it again, they're fine. The other 4%, they may get a rash again, but it doesn't cross over to cause anaphylaxis. So bottom line is, this is becoming more and more talked about in the lay press and media and among allergists and physicians. Talk to your doctor. If you are one of those people walking around thinking you're allergic to penicillin, it's worth revisiting. We know that patients who have a penicillin allergy label, it stays with them for a long, long time, they don't do as well. So they get inferior antibiotics, they're more costly, they may have more side effects. Broad spectrum antibiotics are a bad choice. Penicillin's a great antibiotic for a lot of common infections like strep throat and ear infections and sinus infections, things like that. And with the rise of antibiotic resistance, this is a big problem on a population level as well.
For sure. And interesting to note, I actually, we just talked off camera, have had and currently have a reaction to penicillin, specifically amoxicillin. When I was 13 years old, I was incorrectly prescribed amoxicillin for what was to be a virus called mononucleosis. Now, in certain cases, I believe 60% of the cases, you will develop something known as a morbilliform rash, which is a full body rash, pink papules, macules, that is essentially a drug eruption from taking amoxicillin with mononucleosis. Now, after that, there was only one more instance in my life, a year later, that I took amoxicillin. Same thing happened. I realized I was allergic, and now in my chart, it says penicillin allergy. However, most recently, I had a really bad preseptal cellulitis, which is the infection of the skin surrounding the eye, and I was prescribed antibiotics. I forgot to mention, my mistake, because doctors are really bad patients, that I had an allergy to amoxicillin, took it, and what do you know? A few days after I finished my course, a delayed reaction, I don't know if you guys can see it, I have a full body rash, this morbilliform rash, drug eruption. What do you think about that?
You're the rarity. Yeah.
Yay!
Despite your asking, I'm not going to do the full body exam. I take your word for it. But no, so it can happen. But it's also important because you didn't have a severe anaphylactic reaction, right? You developed an annoying rash.
Yeah, really.
So you're the exception, not the rule.
Yeah.
And it's most likely in your best interest to avoid penicillin.
Sad. Now I have to deal with the inferior antibiotics, increasing resistance. No, I'm just kidding. Yeah, I mean, look, each individual case requires individual decision making and shared decision making. So I'll live with this. I'll be okay. It's not the end of the world, but it's definitely not fun to be covered pretty much neck to toe in a rash. So if you do have this, I feel for you. We can have that bonding moment.
But most importantly, and as awful as this is for you, for every one of you, there's 9 people out there with the same story when you were 13 that can get it again. They're fine.
Yeah, exactly. So that's why it's important to have the conversation either with your primary care doctor or if they're unsure, get an allergist involved. We have one right here, and information's down below. We covered everything there is to know about allergies. To learn more about Dr. Stukas and everything that he's doing, links down below, Twitter, where he works, all that great information. And if you want to check out some other cool playlist videos about medical cases, click here. As always, stay happy and healthy.